session on Professor DVR, you'll have to go on mute, please. And Professor Atul. So, good afternoon and welcome to the webinar on COVID-19, epidemic to pandemic. We are, for the first time in the webinar sessions, we are going to get a perspective of Government of India and AIIMS response by none other than Padmashri Professor Atul Kumar, Chief and Professor of Ophthalmology at the Dr. RP Center at All India Institute of Medical Sciences. And this session is being conducted in association with Equitable Healthcare Access Consortium, and we are delighted to partner with them. This is an organization which has a focus on ensuring and spreading equitable healthcare to everyone. I am Soumya Shashidhara, the Associate Director at the Max Institute of Healthcare Management at the Indian School of Business. I would also like to introduce Professor Divya Sheshadri. He is a professor in the marketing area at the Indian School of Business, and he wears two hats. One as the professor at ISB, and also the other hat is as secretary of the Equitable Healthcare Access Consortium. He has been one of the people who kind of proposed and got this idea on road. I now hand over the mic to Professor DVR, who can talk a few minutes about EHAC, its objective and what it intends to do through the organization. And then we will soon be back at the session after the introduction. Professor DVR, over to you.
Thank you, Soumya, and friends. It's my pleasure and delight to introduce Equitable Healthcare Access Consortium. I'm also happy to introduce Arnaz Dalal, who is on this call. He's the CEO of the consortium, and this is, you can access it through ehaconsortium.org. In any case, if you Google, you will find it. My purpose here in the next 1 minute is to briefly walk you through what the intent of this organization was when it was started. And I'm happy to report that now we're growing from strength to strength. We've been around for about 2 years, and the stalwarts in the healthcare, several of them have been members organizationally and individuals as well. But the core idea is, for any stable society, we need a guarantee for the poorest of poor to have access and high quality delivery of healthcare, education, and livelihood. Of course, currently the focus, as the name suggests, is on healthcare. And so basically we have seen a lot of wonderful models practiced in India, whether it's LV Prasad Institute or Arvind Eye Care or Narayana Health and so many others. And so we thought, can we create some sort of a mutual learning and synergies between them and also to others? And very ironically, many people think once you get into equitable healthcare delivery, it cannot be profitable. But these exemplars have actually demonstrated that it's possible to do well and to do good. So this is quite an incredible initiative, and it's going from strength to strength. You're welcome to join as members, individual, or as institutional. And really, we want to take the footprint to all India. With this, I'd like to hand over to Dr. Raja Narayan, who will introduce Dr. Atul Kumar, the speaker of the day. Over to Dr. Raja Narayan. I'm muting my mic now.
Good afternoon to everyone, one and all. On this important topic, it is my pleasure to introduce Dr. Atul Kumar, who actually doesn't need any introduction to ophthalmologists. Everyone knows him. But since there are many others in this meeting, I will just give a brief introduction of Dr. Atul Kumar. He completed his MD and senior residency from the prestigious Rajendra Prasad Eye Center, All India Institute of Medical Sciences, and joined as faculty in Vitro Retina in 1987. And also did his Retina Fellowship from the prestigious University of Maryland in USA in 1990. He has published more than 300 publications. He has written a book on medical and surgical retina management and has over 24 book chapters. He has numerous awards to his credit. It's a very, very long list. But just to keep it brief and relevant to this important topic of today, he got his fellowship from the prestigious National Academy of Medical Sciences in October 2006. And then he was awarded the Padmashri by the Government of India in 2007. He is also the advisor to the Government of India for ophthalmology, and he got his FRCS in 2017. And currently, he is the chief of ophthalmology at RP Center AIIMS. So, over to you, Dr. Atul Kumar.
And I must really honor that ISB along with this consortium, this health consortium, which is spearheading this along with the LVPI, Raja being representing them, having asking me to speak on something about the AIIMS initiative as well as the Government of India initiative regarding the COVID or the SARS-CoV-2 disease, the virus causing the disease, and which has come as a havoc, gone into a pandemic from an epidemic. So without wasting any time, I'm going to go on to my presentation, and I can assure you it won't be a very long presentation, and we'll have enough time for discussion and question answer. This is very important for any presentation. So, you already know that we've reached pandemic levels for this disease, and it's basically a reservoir of this coronavirus. I just want to introduce, we all know it, but it's bats and civet cats, maybe pangolins, and of these wild animals may be the cause, or as some say, I don't want to get any controversy, that could be from the Wuhan Virology Center, accidentally or whatever leak. Anyway, it causes very severe respiratory infection and usually causes breathing difficulties in the comorbid patients who are older, as well as they have some cardiac issues or hypertension. They are the ones who are at threat. 80% people may not actually know that you have the disease. Another 15 to 17 would feel that they have a mild upper respiratory infection. It's only the 2% mortality is there. In fact, it's less than the SARS, which had about 8 to 10% mortality. Pneumonia can be there, which can be very severe in this 2%, which can be fatal because you have to be on ventilators. Once you go on a ventilator, it's very difficult to get off it. So India really fought back, and I must say that not because of any other reason that I'm working in a government institution, but we really fought back well. And when we really found out that there was something coming in from Wuhan, and based on WHO information as well as from some other countries like Italy and all, we put the international travel ban straight away in 22nd March. Some people say it could have been earlier, but it was there, and it started seriously screening everybody who was coming from abroad with these infrared non-meters where you could sure the national lockdown was proclaimed by the Prime Minister of India on the 25th of March, right there for 3 weeks. And it was similar to what was being done in many countries, including USA, social distancing, as well as Italy and many European countries. UK have come down with a very strict lockdown. Even Singapore, I believe, has gone into a lockdown now. So, of course, all this was very important. It should not be, given importance. There's a dedicated website. You go to mygov.in/COVID, and you can obtain all the latest figures, the what do's and don'ts, and all what you should know. Now, the government has also launched Arogya Setu app, which means Bridge of Health app. It means in Sanskrit, Bridge of Health app. Arogya Setu app. You can download it from this mygovernment.in COVID or any, just type out Arogya Setu app, and you'll be able to. It's a Bluetooth base. You keep Bluetooth on, and it's a tracker. You feed in your data. If you ever get the disease or somebody gets a disease, that it is put in. Your travels abroad, everything is put in. So helps you to know what is your status as well as how close are you to another person who may be having the disease. So if you're in a green zone, you're in a safe zone. So India has actually, but this is a Government of India slide which I've taken out, and it shows that advantages of social distancing and lockdown. You would have actually had about 8.2 lakh cases by 15th April. This is around the same time which we are sitting here now. And India was expected to get about 8.2 million cases. Because of the lockdown, I just want to go down to the figures here. This is 17,000 cases as per the lockdown figures. This was in March. They had said that we would be having about 17,000 odd cases in April 15th. But right now, as of we've got about 13,000 cases. So it's still well short of the 17,000 which was expected. So India is really doing well. Most of our beds are empty. Like I tell you, the trauma center names, which has been converted to a COVID center, has just 2 patients. It's not like that in many states, of course. Maybe Maharashtra has more cases, but Rajasthan and many other states have really come down. Nevada example has been very good, really locked down well. So lockdown has a major role because Italy is totally locked down again for another 3 weeks. So it is a role. So projected figures are much lower. Most of the private hospitals also, which had given allocated beds are lying vacant. We were hoping we were not, we were just thinking that we would have had a major influx of patients, and the whole hospital would be flooded. But we were prepared for it. But because of such like has happened, even AIIMS has got very few patients. The main AIIMS complex has no patients, in fact. It's only the trauma center which we converted and the Jhajjar center. So this is another thing about the ICMR guidelines about hydroxychloroquine, which is a burning topic. Should we take it or not take it? There's a lot of talk going around, and some people say you should just take it up inside the mouth. But there are certain guidelines. Eligible individuals are the ones who are asymptomatic health workers directly in the treatment of patients who are COVID positive. That means those health workers who are working in COVID wards or in screening areas or in the isolation wards need to take this definitely. And because it has some side effects. Asymptomatic household contacts in lab positive cases. So all the household contacts, these lab positives come back, so probably you need to take doses. So the dose is given there, and it's given about 200 milligrams twice a day, and this is followed by 400 milligrams twice a day, followed by 400 milligrams once weekly for 7 weeks. There have been some reports from France that there have been cardiac arrhythmias and so on and so forth. So it's ideally you should consult a physician before taking this dose. Just don't take it with you, and because it's basically for people who are directly treating this thing, people who are treating the COVID positive patients. Now, AIIMS come out leading the fight against the government. In tandem, we have a COVID hospital, which is a trauma center. We've got a center hospital, which is trauma. Center is a center. And the Jhajjar hospital, which is about 800 bedded, has been converted to a totally COVID hospital. We've got wards, one D6 and C6 on the 6th floor for the patients who are who infected or who require treatment, mostly the health personnel. Health personnel of AIIMS who are working, they're also given space because they're the ones who are most chances of getting affected. You see, we are hearing about health personnel being beaten up, doctors being beaten up, and doctors also having the disease, and the health personnel also means sanitary person also. So we've got ward for them also. We've got private ward rooms also for the AIIMS staff. But of course, the hospital and the center is for everybody. We have these educational apps there. If you go to the AIIMS website, you can just download what all you need, educational apps. And now coming to the very important thing about the N95 respirator, there's a lot of lexicon included now in your jargon, the medical jargon. You've got quarantine, you've got social distancing, which will stay. All these words will stay for a long time. The N95 mask and the surgical mask, the cloth mask, all these things are new things which will come into our medical lexicon. So they came once N95 ideally in short for people who are directly caring for COVID-19 or aerosol generating procedures. Now the government of India as well as CDC has said you should wear a mask. Now why should you wear the mask? Because the aerosol is a form of the floating virus particles. What happens if a person sneezes? You get large droplets which will fall down, but the smaller droplets, the fluid around the mucus around the virus dries up, and the virus is floating in the air. Shown in New England Journal of Medicine also, and the AIIMS also say there is a half an hour to 1 hour, even 2 hours, the aerosol generation, and which is there in in places which are closed. They want rooms to be well aired. They want that you should not be too close to each other. If you are too close, wear the mask. The mask not only protects the infected person, but also protects the other person. The viewpoint is changing that if you've got this aerosol in the air, aerosol is kind of airborne disease. You better wear this mask for your protection against that aerosol. Therefore, the Prime Minister, the government has been insisting that we shouldn't use the N95 for these routine purposes. Medical masks, surgical masks in the hospitals, and probably even a cloth mask or bandana should be for everyday use, but it should be used. As of now, the government has been very, very strict. They put a ban of 2,000 rupees. I wish they put it years back. 2,000 rupees on a spitting in against anywhere in the road or anywhere. Finally, we are waking up to a lot of cleanliness drive and sanitation drive. So regarding masks, we also have come up with a strategy of a standard operating procedure that we give 5 masks N95 to everybody who's working in the hospital. All hospitals could adopt this if they wish to, but you can save up on the costs because you don't have to use it every day and throw it. You got to put it 5 masks, one is reserved. So 4 masks, you wear one for one day, and then after using it for one day, put it in a brown bag, let it dry. Second mask for the second day, put in the bag and dry. The third mask for the third day, put in the after using it, put in the bag and dry. Fourth, like that. Fifth day, you take first bag, which is marked 1 by you, and you can take it out and wear it again. So again for 4, 5. So you can use these 5 masks with this reserve. 4 masks you use, 5 reserve for about 20 days, and this works well. And the AIIMS guidelines definitely say that this is what they're doing with us. So they're not going to spend a lot of money on unnecessary buying N95, but they're going to give us a 5 masks for over 20 days, which will help us because whatever said and done, all of us, hospital doctors or wearing in medical care facility, need to wear a mask because 99% of 95% of viruses are filtered out. Now, DRDO is going in a big way from missiles and from guns and to armaments. DRDO is developing a lot of things, including N99 masks. They're developing special for the armed forces form of a sterilium hand cup. It's going to be very, very cheap. They'll give it free of cost to the armed forces. So a lot of good work being done by DRDO. And one very interesting thing they've come up with, just show you. So we at AIIMS are also developing personal protection equipment. Again, a very burning topic. In AIIMS, we feel that every area has to have its own, you know, if you're in a screening area, you have to wear. I've got a video on that. Small clip if I want to show you for 5 seconds. And you got to wear a water-resistant gown. You got to wear double gloves. You got to wear a face shield. You have to wear a head cover. You have to wear stockings or something to cover your legs. That's what you got to wear. Double gloves. So all this is very much required. If you're going to screen a patient or you're going to take samples, you have to wear all the clothes. There's no question that the PPE is not required for areas which are treating or hospitals which we may be exposed. Very good, still special areas going to screen patients. But for others, probably only a surgical mask is enough for going out for the normal public, a cloth mask is enough. But all the hospital areas, you have to have these identified areas where you go to have screening, lab testing of patients, or the medicine and all that. For ophthalmology, maybe we don't need it as much, but because we refer the case to the medicine department. But this is the way the doffing is also being taught here in AIIMS, to wear the clothes so that you don't contaminate the outside too much. And the doffing is most important, how to take it off. Like your glove is out with the pinch at the palm, and you peel the outside very carefully, and the inner glove is taken out later. Each step you got to hand your hand. So you got to wear mask, you got to wear a head hood, you have to wear transparent goggles or a face shield, you have to wear a neck cover, you got to wear waterproof goggles, and you got to wear feet like cover foot covers or leg covers which go up like to the knee. You got to care for yourself very much. DRDO has come up with a very good idea for the disinfection chamber, despite some controversies in the last 2 days that somebody got some skin rash and all that. But this is sodium hypochlorite chamber, and at one time they fill up about 650 patients can pass through it, and you can just walk through this chamber. And it's a government of India, mainly a DRDO initiative, and they've come up with this incredible thing of having a. So we got to standardize it. The AIIMS is trying to standardize it. We placed one of the chambers here. This is near a casualty at the AIIMS. So what we're going to do is to standardize this. The government, and the DRDO and AIIMS is going to standardize it. How much solution we use without causing any skin rash. This will help prevent people from, kind of disinfect the person from his outside before he enters the hospital. AIIMS RP center approach is also very important. You got only emergency cases at edge. It's like in a battlefield, we only got to save the most serious patient or age, depending on age. In Italy, they had to save the younger people first. They let the old people go. So Italy had a major problem because of their was in Wuhan. But luckily for India, we don't realize what we would have been in for. Right? We're sitting quite. I think Telangana has also very few cases, maybe 100, 150, not more than that. This is a small number considering our population. And even in UP and Delhi, Delhi has cases, but it was due to some incident. But right now we are in a very proper way. AIIMS is totally having hardly any cases, and even RML has discharged many of the people who got okay. So 80% will be just asymptomatic. So of course, this disease will be there for a long time, but we've got to look after ourselves. So like in the ophthalmology, we were designed from X-ray plates, this special slit in the X-ray plate helps us to put this film between the doctor and the patient is on the other side. The doctor is looking through this eyepiece. He's got his face mask, and the patient may cough or sneeze, or he's in close proximity, more than a meter, less than a meter. This X-ray film really helps. So we put this on all the street lamps. And what we've done, we've indigenously designed our pharmacologist, ocular pharmacologist, Dr. Pelupandian. He's so innovative. He designed a small acrylic sheet. He's cut it into fine bands, and this acrylic sheet attaches to a fine plastic film. This plastic film is foldable, flexible. So he's bought a lot of plastic steel. We told him to go ahead, and he's making by the dozens. So we use this plastic steel, which is attached to the polyacrylic this thing material, and this we just put it right behind the. There's an N95 mask inside. This is in the casualty. So though of course it's recommended only for primary health workers, but you don't know what exactly is the. You will be having a asymptomatic patients in the incubation period. So we're using N95 for only the casualty patients right now because the routine OPDs are not running. Then we got this face shield, we've got this gown, and he wears gloves, and that's about it. So routine application, tonometry, and CT we are avoiding as far as possible. Endoscope should be definitely avoided. Indirect we are preferring, and elective surgeries we are deferring as if there's a severe. If there's a serious patient, of course, he's got to be taken up. Is the same thing that we try to do for patients with no emergency, and they can wait for a month or so. The disease goes down. It's not going to die away. But the only way this disease is going to go away is probably having a vaccine or herd immunity, which you all know of. Now, coming to some interesting slides, that the company called MyLab, which is partnered with the Serum Institute of India at Pune, the private partnership. They've actually come out with a phenomenal low-cost PCR kit, which ICM has approved. This PCR testing will cost you 1,200 rupees only. It's a fast test. It's good. They are promising 20,000 tests a week possible. The mass production from my lab, along but it's using Serum Institute of India. I think it's Cyrus Poonawalla owned Serum Institute of India. So they're coming up, and Cyrus Poonawalla Serum Institute of India is also coming with the vaccine. It's actually the private side which is doing a hell of a lot of work on vaccines, and Zydus Cadila is also involved in the vaccine. Besides other things like hydroxychloroquine and all, India has the highest production of. So there are many labs which are now approved, and ICMR has put the cost as 4,500 per test. So there's a Supreme Court to do it free, but the ICMR actually that. The ICMR says that when you at 4,500, there's no question of free. When the doctors can't do free work till what time? Even nursing homes, hospitals, but centers cannot run free. So they have to charge. They've already beds aside in the general hospitals. That's the maximum anybody can do. So Apollo Hospitals, Pratap and his team has come up with this project TI, innovative strategy to create medical rooms in hotels, hospitals for light supervision. So you could self-quarantine or a mild attack of COVID-19. He doesn't need to rush to a hospital. Or he take up hotels. So he's taken up some hotels and hostel rooms where he's going to keep staff there. And, that's a very good project. And you don't have to overload the main hospitals. Those hospitals in Delhi, Max has got wards and Garam has got, but there's a question of also that, the private sector, I think, is earmarking a lot of rooms, but they're all going vacant. Good thing is they're all going vacant. Why is it a good thing? Because you just got 13,000 cases, which is nothing. Prime Minister, the government of India's initiative of lockdown is a big, major success. As of now, I have nothing to do with being in which job. I feel the private hospitals also need to be looked after. They have a lot of, there's very few patients coming in there. There's a financial crunch, as they say, and they are putting a lot of money on PPE and all that. But probably they can carry on for a couple of months, but not more than that. But I think the American Academy of Ophthalmology has just come out that the US government is giving a grant to all the suffering units. So I think we need to be looking after the private sector as well as the government sector. And luckily for India, it's not such a big problem. Of course, you got to live with it for a long time, but suppose with the vaccine and herd immunity, things will die down by the end of the year. Because it will take about a year for the vaccine to come out. I invite any questions. Thank you very much.
Thank you, Professor Atul. Now I invite participants to send in your questions in the small box which says Q&A to the right side of the screen. And before we go on to the questions by the participants, I want to invite Professor Divya Sheshadri if he has any questions for Professor Atul Kumar.
Soumya, could you read that out or you want me to read it?
No, sir, I'm asking if you have any questions while participants key it in.
I have put it in that chat box. I'm putting one more after this.
Can I ask one question?
Please go ahead, Dr. Raja.
Yeah, thank you, Professor Atul Kumar, for the wonderful presentation. I have a question on how we can come out of the lockdown. When we come, what would be the changes in the way people manage the hospitals and clinics? In India, generally, hospitals are always known to be crowded. There is usually no appointments. Usually, they're all walk-ins. So there is going to be a huge problem of managing crowds in the hospitals. So in this context, the telemedicine may be useful to some extent, and the government of India has given some guidelines. So can you shed some light on how we use telemedicine to reduce the crowd, and also maybe some management of cases with telemedicine?
Rather, the thing is that telemedicine does help because certain patients who are old and they're informed they can't come to the hospital. They've already been treated and they just want some information about the symptoms which are mild. Because thing is about telemedicine is you can look into the eye and you can maximum look at the cornea also with very minimal magnification. Only little information you can get about the actual state of the eye. Somebody is saying I'm having floaters or a cotton, he'll have to come to the hospital. But of course, for routine minor ailments, especially for the physicians and say if vision chart we can project, but for other things like ECG and all, they can show us. But for cardiologists, but I think for minor ailments, it's a very good tool that telemedicine. I agree with you. We've also taken these AIIMS has started an initiative of telemedicine now. The RP Center has bought in some, phones, and we are going to start using this. And I think the future with the telemedicine will be now it's become legal. From illegal it's become legal, and now with the problems of load and rush, I think many of these minor issues can be solved on the using telemedicine. I agree.
Thank you, sir. Soumya, you have other questions from any participant?
Yes, we have Dr. Amaresh Rao. Dr. Amaresh, good to see you at the webinar. Amaresh is an alum and a senior doctor from our advanced management program for healthcare. It's a mid-career healthcare management program that the Indian School of Business runs. his question is, are all patients for emergency surgery screened for COVID?
All emergency patients, should they get tested for COVID?
Yes, he's asking if the emergency surgeries that are happening right now are being screened for COVID.
No, they're not. There are no such guidelines from the government. And see, there is a big elephant in the room about this. Whether everybody who comes to a hospital should be tested for COVID. You would overload our labs and probably spend a lot of money of government as well as your private setup. When it's a private hospital, they have to spend a lot of money, because the patient may ask for reimbursements and the various problems are there. You'll come into your total, charge for the patient. Until I feel recently the Americans are just reading on the network, the CDC not recommending tests. Even the US CDC team as well as the NIH team is not recommending, the professionals, the health professionals are not recommending that until you have some history of travel or respiratory infection or some contact with some patient. They're not recommending routinely that we should be getting every patient who enters the hospital get a COVID testing. It's something like every patient gets a BCG test, so fine, he gets PC positive. So I think once the vaccine comes, things will be much better. But as of now, we shouldn't kind of overload the labs, and because there'll be many patients who really require it. Other people who don't require it just because they want to come for a surgery. It's a tough one, but I think as of now, the US government as well as the Indian government both are on the same plane, and they're not recommending COVID-19 testing, PCR testing for any patient walking into as emergency case.
Yeah, I agree completely with Professor Atul Kumar. It will overload the system. Plus, there are issues with the testing. Also, there can be false negatives. There can be window periods. And you cannot know who is actually a silent carrier and may transmit. So, at this point of time, the universal precaution is what needs to be followed. I completely agree with Professor Atul.
Thank you very much. Dr. Amresh has a follow-up question on healthcare personnel. Are they being regularly screened for COVID given hospitals are the hotspots? That I think is a very relevant question and on top of mind for all frontline healthcare workers at this point. So I invite Professor Atul Kumar to take this question. Thank you.
This is regarding healthcare workers, their screening.
That's right, sir.
So I think all the healthcare workers should get the COVID testing definitely, because they are at high risk and they themselves have to get their COVID test done, and at least 2 nasal swabs should be taken at a week apart, and they should get it done. And they say they're also still quarantined. Every healthcare worker who's directly dealing with the screening or the treatment or the isolation cases in any of the cities or smaller towns has to be quarantined for 15 days. Like the AIIMS says that any of the doctors, healthcare professionals who come in contact with treatment of a COVID patient has to go back and self-quarantine himself or herself for 15 days. Also make yourself tested. I think that's important. Of course, you have to take all the rigorous precautions. You have to literally tie yourself up with a spacesuit up to bottom.
Thank you. Now we have an ophthalmology-related question from Dr. Tanuj Dada. Any risk of retinal toxicity with HCP prophylaxis? Sorry, I'm not a doctor, so excuse my pronunciation.
So we had none. We'll have to test for vitreous samples in a COVID positive patient. We haven't got any data yet, as yet, about vitreous samples or the aqueous vitreous samples, whether it goes in the eye. As of now, what we get is a conjunctivitis. That's also very rare. The Wuhan statistics say that hardly 1%, 2% of the people had conjunctivitis. The eye presentation may not be so common. I mean, the COVID patient coming with the eye presentation is very rare. It's just 1 to 2% of Wuhan figures. I haven't seen any eye patient who's tested COVID positive who had conjunctivitis. All of them who've come to the AIIMS with eye congested and a congestion and conjunctivitis were never found to be COVID positive. They were tested.
So Dr. Samantha asks, how do optometrists do refraction in this situation?
So they're going to wear surgical gloves, surgical masks, and probably face shields to do it. Because these face shields will be of great use, or goggles. We need something for our eyes because they can be, sneeze or the cough can bring those droplets right into your face. So something to cover your face is required besides the breathing part, the respirator. I think something for the face will be required. So there has to be mass production. A lot of companies and a lot of, I think everybody is coming out, all the government and the private agencies, low cost masks, face shields. Surgery also probably through the face shield, or a face shield would be the best. Because any spray of a sneeze would at least be taken care of by the face shield. We'll have to use these face shields when we're actually doing some procedure for at least few months. This will carry on for maybe 6 months or a year. And gradually, as the disease dies down with vaccines and all that, of course, it'll be low at it won't totally go away. But probably at least 6 months, we should have the face shields. I think so.
Great. While we are on ophthalmology, there is another question, so I'm just going to move straight to that. There's Dr. Pooja Pandey. She asked, is there any specific test to diagnose COVID-related conjunctivitis? What is the treatment for it?
What they say is that it's follicular conjunctivitis. It's like any other viral conjunctivitis. It's just a virus. You don't have to get fearful or fear. We think paranoid and also very fearful of it. It's like a conjunctivitis. Like so many of these viral conjunctivitis, which we get is epidemic conjunctivitis. So it's the same treatment, antibiotic drops. You don't have to put some specific chloroquine drops or anything. You just got to put some antibiotic drops in artificial tears. We can finish. And probably stay away from others, as you usually do for all conjunctivitis. Because they are contagious. All conjunctivitis, whether they are COVID negative or COVID positive, they are all contagious. You've got to stay in separately, isolate yourself. In case you develop fever and respiratory breathlessness, you get some fever, you get some breathing problems, then you need to get yourself checked. Of course, every conjunctivitis would have to get a COVID testing. May not apply totally. There's a gray zone there again. If you develop systemic symptoms, then of course you should. But if you don't develop it, you can wait for a day or two and wait. Because the first 2-3 days, the test may be negative, the PCR. After the third day, if you still feel you're getting systemic problems, then you better get yourself tested. After 3 days, your conjunctivitis is subsiding and you don't have any systemic features of any URTI or fever, then I don't think you should go in for it. As I said, many will become asymptomatic. We'll soon become, carriers of like the BCG. We're not immune. Those measles, mumps, we're immune to get these diseases because we got ourselves vaccinated. So the vaccine will play a major role. Herd immunity will be the other thing. And vaccines will come out in a year.
Great. Pooja has a follow-up question. She wants to know how much protection will be provided by plastic sheet putting in front of slit lamp.
Plastic sheet putting in front of the slit lamp. I think a big major advantage. It must not be ignored because the person sitting there is very close to where your face is, and you'll inhale all the droplets and the aerosol. The aerosol is going to play a major role. This aerosol is through in the air. The rooms also should be very ventilated. The windows open, because you let the kind of fresh air come in, and closed rooms will have more chances of infection. So these screens actually prevent the mechanical movement of the aerosol related infection. It's a very simple way, the X-ray film, used X-ray film. I'm sure a lot of companies will start making it low cost. If not, the X-ray film is free of cost. It will cut down our costs. Because even private hospitals would have to add it to their bill. I mean, it's going to be very expensive to buy all the PPE for everybody. Whatever is necessary, only that. Whatever you can indigenize, will be the best. Make your own screens and kind of share it among each other. We the amount of screens you are making, we're ready to share it with the Delhi hospital. Because Velupandian is making it on mass scale now. I'm sure everybody can make those, they're using those helmets with that ring on it, and they use the front screen. Just the front screen, not the helmet. So everybody's kind of innovative.
Thank you. So those of you who put the question into the chat box or directly to Professor Atul Kumar, I request you to please put them in the Q&A section so that I can read it out to Professor Atul Kumar. Before we go on to the next question, I would like to invite Professor DVR, who had a question to ask. Professor DVR, please go ahead. And participants, please put in your questions in the Q&A section and not in the chat box. Thank you so much. Professor DVR.
Dr. Atul, it was a fantastic eye-opening presentation. Thank you so much. I had a couple of
My
small
honor
questions.
to deliver it to ISB and Health Consortium.
Thank you,
It's a
sir.
very famous institute in Hyderabad, and we've always looked up to it. And it's playing a major role in India's, management. The private sector is playing a major role. The ISB is very well known now.
Thank you, sir. So I had a couple of questions. I don't know if I can ask all in one shot because Soumya may not give me another turn. So the first one is that when we put the face shield and a patient, let's say it carries the aerosol or he coughs and those droplets settle on the face shield, how long will it take for those virus to actually die its own death? Because after the procedure or after examining the patient, one will take off the face shield and he might actually accidentally touch it, and so on. So is there some precautions that have to be taken? Does he have to wash that face shield? Yes.
Use some sterilium to wipe it, sir. Wear gloves and put the sterilium to wipe it. Because sterilium is very good. Even on the when you're donning and doffing, we use sterilium very handy. Wherever you feel you contaminated your suit or your face shield, you can just take some cotton or gauze piece and take the sterilium. I mean, sterilium means any alcohol-based these, hand rubs. It will kill all the it's virucidal. So you just clean the face shield. I suppose this will be disposable, and so we should try not to put it from the outside. When we get it out, we have to the perfect technique for the face shield is what Tim says is take it from the backside. Take this band off from the backside and then close the whole thing. So many of these would be single use if they're reasonable, but the ones we are making are very, very reasonable. It's going to be free of cost or just maybe less than 100 rupees, or even less than 100 rupees. Because it's just a plastic, we need a thin plastic, foldable plastic. And it's about a A4 size. It's the size of a A4.
Our next question is from Dr. Sonia Pant. She asks a question that is relevant to the post-COVID period, or at least the critical part of the COVID period. She wants to know if everything settles down and then they start screening for school eye screening activities as well as the outreach activities to screen refractive error cases. She wants to know what is the kind of protective gears that they need to, the medical staff will need to wear. Is this going to be, do they need to wear full PPE or mask, or just gloves and face shield or protective glasses would be sufficient?
Just glasses, protective glasses, and gloves should be enough. A mask, a surgical mask would be enough. Just seeing routine school children, there's no active disease, maybe. So a surgical mask also is very good. It's a 3-ply mask. A surgical mask is enough. You don't need to waste money on N95, which may cost 300 rupees. This is a 10 rupee mask, 10 to 15 rupee mask, surgical mask, and it can be used in abundance because it's so reasonable. Probably you need a face shield or some goggles. Transparent goggles can be very nice. The gloves again come about 10, 20 rupees. These surgery wear and all these gloves are very cheap if you buy in bulk, as well as these masks. The surgical mask should be enough. We shouldn't overuse the N95. I don't think we're going to get any advantage of using N95 everywhere. Surgical masks, gloves, and some goggles, transparent white goggles.
Okay, great. So the next question is from Dr. Chaitra Jayadev. Are you worried about liability if your staff or patients get infected and claim to have got it at your workplace? By that, she would mean the hospital in which they come for their treatment.
Suppose if you lay down the guidelines for a hospital SOP, there should be no reason for you to be worried. You should get it screened by a lawyer. Unnecessarily worrying too much that everybody is going to be threatening me and taking me to court would not be right. If you tell your workers that this is what we are doing, if you want to add anything or something, it's not that we're going to add everything what they say, but what justified if you're doing and shown to a legal person. Because if you take the proper measures in the hospital that you have distancing, everybody who comes in, he gets this sterilizer, and if he's coughing, then he goes to a medical medicine department, or if you want, you can even wear a mask himself, give him a mask. But otherwise, if you maintain this thing of wearing a face mask, because these workers can just wear a surgical mask and they're not exposed to a COVID ward. They're not working in a COVID designated zone. They're just working in a eye hospital, so like Narayan Health. So they can just wear surgical mask at 10 rupees a cost. They can wear gloves. Gloves, you touch surfaces because this COVID virus is notorious to stay for 5 to 7 days on stainless steel and plastic. It's important we clean our surfaces, especially these very smooth surfaces, clean with sterilium. And sterilium, I think, also bulk. We anyway use sterilium so much. Otherwise, also we use a little extra sterilium and clean off these bacillocid. We just spray this or surfaces like we usually do for all hospitals. And then after that, I think once these things are down on paper, approved and signed, and I think the hospital, the circular should go around and this is what we are doing. And to authorities, also to the health authorities of Karnataka or Bangalore. And once that's been done and the SOPs are laid down, then just like we give an intravitreal injection in the eye or some other procedure, this is also part of the procedure. So then I don't think a case would hold in court. It'll get thrown out, definitely.
Yes, sir. So I have questions on the safety of healthcare workers, and I'll just combine it and ask you. One question is from Anshu Bhargava. The question is about healthcare workers contracting COVID while treating non-symptomatic patients, and what should be the precaution. And also the other question is from Muralidhar Rao. He asks, what should be the OT protocol in the present scenario, especially for the COVID positive patients?
The second one first, the OT is very important because the anesthetists are there. The anesthetists actually are the more at risk. They're going to intubate and also they're playing with upper respiratory tract. We're going to put intubate the patient. So the anesthetists would have to wear. I was just thinking in the morning, the anesthetists have to play a major role in themselves. So the doctors and the healthcare personnel have to really look after themselves. Of course, it's important because they don't want to contract the disease, and if they do, of course, it's mild, but you shouldn't get it. So the face shield again comes on. We all wear caps, surgical caps. We wear a mask. Only the anesthetists can wear a double mask, a face shield, gloves, and a proper splash-free gowns. You'll have to get these gowns which are not having any water, doesn't soak into it. So splashes, but these things would be required, and they'll have to wear a face shield for the whole face. I think face shields or transparent goggles would be required in addition to what we are already using. Because we're still using masks, we've been using caps, we've been using gowns. So along with that, we're going to use a double gown, a mask and a face shield or a goggles. So I'm sure face shields can be made by many companies as well as people like DRDO and all can design, and many private companies would come up with it. If DRDO from missiles has come down to 99 masks, that's a big When I believe Armani and all these big, fashion brands in Italy are now making suits and PPE and masks and these liquids, sterilum-like liquids.
So we're going to take the last question now by Dr. Sonia Pant. Precautions for healthcare workers providing essentials and sanitation kits in the community. Is that an option? Do you have any guidelines to wear gowns required in these activities? I think she means while going into the community and giving essentials. That is what Dr. Sonia Pant asked.
If you're going to community, because there may be a lot of people who've not been, you don't know who's who, and you also don't know somebody's having some URTI or something. It's better that you wear a proper gown. And you don't have to wear a TIVAC suit, like we've ordered 8,000 TIVAC suits for our people who are working in the COVID hospital. Those are special suits which kind of totally zip up, and they have attached with a face visor. So we don't need those, but we need ordinary surgical gowns. We need to wear gloves, and we need to wear a face shield, and have a face shield, and we'll have to wear masks. If you go to in a community, I think it's better we protect ourselves with all this. It comes down to the same thing each time, that we need a face shield, or in addition to the usual. Of course, gloves are not going to be of great help, because any area you got to be, the gloves. You double glove yourself, that's also fine, because if you go into community, at least the double gloves will help.
Now I invite Dr. Raja Narayan to add to any of these points and share any experience you have before we conclude the session.
Sir, thank you very much. I had one burning question actually. It's about COVID. It has impacted education also. Our residents and fellows, usually they need a lot of practical training. With the patients not coming, and it's even after the lockdown gets over, the number of cases are not going to be enough for the number of trainees that we have now. What do you think should be the strategy? Would we have to reduce the number of trainees, or you have the help of online education more and simulators? What's your strategy for that?
We'll have to move to slowly. We'll have to kind of come down first. We'll have to virtual and since learning more. It'll be the only way in the beginning. So of course, you don't want to expose your residents to sitting too close to each other. Gradually, as the things improve, Raja, I feel we'll come back to classroom. There's nothing to beat the classroom teaching. These virtual teachings may be okay for some time, but we can space the residents out. We'll have to increase our work. Probably work on Saturdays also late. We'll have to have classes at various times for various groups. We'll have to divide our fellows into smaller groups, and so they can space themselves out, and it could be one person teaching them. We'll have to work more. Probably do surgery also. We'll have to work more, because we can't do too much surgery at one time because of the risks of distancing ourselves and keeping the OR clean, and also having not too many patients crowding and attendance. So attendance should not be allowed at all in a hospital. They'll have to sit outside, and only the patients come in. And I'm sure with time, things will work out. But initially, for 6 months maybe, or we'll need to be very strict about who all comes into the hospital and how much load can you take at one time. So it'll have to be really spaced out. I think classroom teaching will have to restart, but probably we can take smaller groups. If the classroom we was yeah.
Thank you so much, sir. I now hand over to Soumya and Divya to conclude the session.
Professor Divya, concluding remarks, and I will announce the details of the next webinar that we are having.
Yeah, Dr. Atul, it was fantastic. I had probably a very high-level question to you, because you're at the core of what is happening in the thinking of the government. And you can choose to just answer it briefly, because I know Soumya is concerned with the time. One is, what is this flattening of the curve, and when will it happen? And related to that is, even after the corona dies out, let's say that there are some 2 people sitting in Perambur in Chennai, and then can the whole cycle restart? And once again, those two infect 200, those 200 infect. Because there are a lot of wide variations on whether it will end in May or September or 2021, or now today Australia said maybe up to 2022. Does one make sense out of all this madness of estimates? What is the government thinking on it? And can the whole cycle restart with just one fellow getting infected, like a late bloomer or whatever else?
So I think first thing I don't think the whole cycle will restart because somebody gets infected because of certain reasons, whether he's contracted from visit abroad, some very high hotspot or what they say as a very high threat area, like some area in Europe or UK is getting it the prime minister is affected there and all that. So I think people would have to learn self-discipline is going to come in a big way. If one or two cases get me, of course, shouldn't panic. The whole country shouldn't be put back into lockdown. It's just we got to take care of those two individuals and their contact. Contact should have to be, of course, looked after because you'll have to immediately see this Arogya Setu app also does we'll have to ask them where all they've been, and so we'll have to immediately put a full listing up. So this will continue for some time, sir. I think once we get these vaccines and all this, it's like as a routine, every child gets MMR, measles, mumps, rubella, and probably gets a BCG for tuberculosis. So we eradicated smallpox, sir. We've done a whole lot of good things. So I think India is in a very health conscious. Not probably we got a very good healthcare. We have the facility. We have the foundation. We can do it if we want to. I think it shouldn't be a panic, sir, if two patients get infected. So two people get infected. So this has to play a very positive role. Social media has to play a very positive role because you just put, it goes like virus. Worse than the coronavirus is the app viruses. It just spreads like crazy that everybody's got a virus in Tamil Nadu or something. So I don't think we should worry so much about it. The hospital authorities there should immediately clamp down and make sure that his contact and everything are taken care of. And that should be it, sir. And second, you said what was the
Flattening and flattening
the
of
curve is going downwards now. The number of deaths have come down markedly. The number of cases also not increasing as per projections. I showed the curve the way we showing. We should have actually had, as per projected figures from Italy, we should have had 15,000 cases despite lockdown. 17,000 cases, but we've not 17. Lockdown, we should have had 17,000 today. 15 people. 16, 17, sorry. So we were actually come to 30,000. For such a huge country, with such a densely populated country, we've done quite well. And we've kept it down to a couple of thousand, to two digits. Two digits. We are still at 12, 13. And most of the cities are showing a downward trend, except for maybe Maharashtra, maybe in Delhi and all. But there's not going to be there's no steep rise or a panic or some kind of a rush to the hospital or something. It's not all the hospitals are lying still vacant. The private hospitals, I've been told that I talked to a lot of people yesterday in various parts of the country. They're saying most of the facilities are ready, but they're not being used till now. Bought a whole lot of PPE, spent money, but it's not being used. We are ready for it, but it's actually not being used. That's the way the trend is going.
I think on that heartening note,
Optimistic.
on that heartening and optimistic note, which I'm sure is the reality from the government perspective, once again, on behalf of ISB and EHS, for your valuable time, both yesterday to make sure that the testing is done so we don't have any glitches, and today also to set up and deliver a very impactful and thought-provoking talk. So thank you once again, and we really look forward to continue to interact with you and gain from your expertise. Thank you, sir.
My pleasure.
Thank you. For the benefit of the participants, I have sent in the details of the following the webinar for the next week in the chat box. On Wednesday, we will be having a discussion on teleconsulting, an idea whose time has come. The teleconsulting has been around for a long time, but looks like the lockdown period has given it a lot of impetus. We are going to discuss what has been the impact on the consulting business now, where do we see that going, and how are the stakeholders responding, especially the behavioral shift that we are seeing in teleconsulting. And on Friday, the 24th at 2 p.m. in the afternoon, we will be discussing healthcare innovation in the times of crisis by Dr. Prashant Jha. He is with St. Thomas's hospital in London, and he's an expert in medtech innovation, and we will be talking to him on Friday at 12 in the afternoon. Please, all the login details are available on our LinkedIn showcase page, Healthcare at ISP. Please stay connected with us, and if you want to write in to us, write in at maxinstitute@isb.edu. Thank you for your participation and time, and moreover, stay safe and stay connected. See you next week on a webinar. And Professors Atul Kumar, DVR, thank you for your time. Dr. Raja Narayan, thank you for your time. And EHSE for your partnership. Thank you. Bye, Arnaz. Thank you. You too.
Hi, Soumya. Thanks.